Hello, my name is Ari Hyder. This is for the FNP program at UofM, section 7463 M50. Today is January 24th, 2025. This is for the spring 2025 semester, and this is my toe assessment. I'm going to scan my room first. These are my supplies. This is just a moving box. See that? Yes, cool. Trash. Alright. Okay, so I've used all the correct patient identifiers. I've washed my hands. I've introduced myself to the patient, and I've provided privacy for him as well. First, I'm looking at his overall skin assessment. We're going to be firstly looking at his head, face, neck, anterior, posterior chest, abdomen. We're looking for color, temperature, texture, turgor, moisture, edema, tenderness, lesions, moles, scars, nevi, bruising, and that'll be done throughout the exam. Right now I don't see any. Everything looks symmetrical. There's no obvious deformities. I'm looking at his head. It's midline to his body. Its shape is normocephalic. I'm going to palpate his scalp. I'm looking for any infestations, depressions, masses. Is any of this tender?
No.
No. His hair pattern is equally distributed. It's smooth and curly, and the color is brown. Next, I'm going to look at his face. Cranial nerve 5 is the motor nerve, so I'm going to have you clench your jaw for me. Good, and then we'll do a little bit of light sensation if you'll close your eyes. And tell me when you can feel the sensation. Just say now.
No, 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 no.
Very good. I'm going to palpate his temporal arteries. Is this tender?
No.
No. And then I'm going to palpate his TMJ while I'm here. Can you open and close? Good. I don't feel any crepitus or subluxation. Cranial nerve 7 is the facial symmetry nerve, so if you could smile, frown, puff out your cheeks, purse your lips, raise your eyebrows. Very good. Now I am looking at his ears. They are midline to his head. The shape looks to be normal or average. I'm going to palpate his pinna and tragus and looking for any masses. Is any of this tender?
No.
Good. Now I'm going to do cranial nerve 8 is the vestibulocochlear nerve. We're going to do the whisper test. I'm going to cover your ear and I'm going to whisper. You tell me what I say.
1, 2, 3. 7, 8, 9.
Very good. Now we're going to do the Weber test for lateralization, and then we'll also do the Rene test. So for the Weber test, tell me if you can hear this better in one or the other ear or equal in both.
Both.
Good. For the Rene test, we want air conduction to be greater than bone conduction. I'm going to give you two locations, location A and B. You tell me which one you can hear it better in. This is B. This is A.
A.
Good. And this is B. This is A.
A.
Very good. Now we're going to take a look at his inner ear structures. His auditory canal is pink and his tympanic membrane is pearly gray. On this side. His auditory ear canal is pink and his tympanic membrane is pearly gray. Very good. Now I am looking at his eyes. His eyebrows extend past his eyelids and they're equally distributed. I don't see any infestations or anything like that. I'm going to palpate for any fissures along his eyes. I don't see any lesions or abnormalities. There's no discharge coming from his eyes. I'm going to look at his conjunctiva. So if you could look up for me, his bottom conjunctiva is pink and moist. His top conjunctiva is pink and moist. His sclera is white. Again, no lesions or discharge. His top lashes curl up. His bottom lashes curl down. Now cranial nerve 2 is the optic nerve, so we're going to test to see his peripheral vision. So I'm going to move my fingers behind you, bring them forward. You tell me when you can see them.
Now.
Very good. Now we're going to do use our Snellen chart to do the rest of that cranial nerve. Actually, this is cranial nerve 3, the oculomotor nerve. So I'm going to set this up. Okay, if you could cover one eye and read the smallest line possible.
LTFPH.
Good. Now cover the other eye and try to read that same line backwards.
HPFTL.
Good. And now read the line with both eyes.
LTFPH.
Good. The patient has 20/20 vision, so that's great. Now, cranial nerves 3, 4, and 6 are the oculomotor, the abducens, and the trochlear. I want you to look past my shoulder up at this finger and follow it. Follow it with your eyes, not your head. Good, that was for convergence, that's great. Now we're going to do the cardinal fields of gaze for extraocular movement. Follow my finger with your eyes, not your head. Very good. 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 All right. Now, I think I've done everything for that. Now we're going to look at his pupillary response, which is also a part of cranial nerve 3, the oculomotor nerve. If you look at my nose. Thank you. Thank you. So the pupils constrict to the opposite consensually, which is good. Now I'm going to look at his inner structures. So if you look at my nose again. Okay. All right, his optic disc is yellow and well defined, and his red reflex is present bilaterally. So that's good. I'm looking at his nose. I don't see any abnormalities. It's straight midline to his face. It looks symmetrical. There's no discharge. I want you to occlude one nair and sniff, and the other. So both his nairs are patient. Cranial nerve 1 is the olfactory nerve, so I want you to close your eyes and tell me what you smell.
Alcohol.
Very good. Now, I'm looking at now I'm going to look at his mouth. If you'll raise your tongue up for me real quick. Now you can relax. So I'm looking at his lips, teeth, gum, buccal mucosa, salivary ducts, the floor of his mouth, the soft palate, the uvula. He doesn't have any tonsils, they've been removed. And his posterior pharynx, everything is pink and moist. I don't see any lesions or abnormalities, so that's good. If you could say, ah, good. Cranial nerve 9 and 10 is the vagus and the glossopharyngeal nerve. And the soft palate and the uvula rose with phonation symmetrically, so that's good. Cranial nerve 12 is the hypoglossal nerve. You can stick your tongue all the way out straight. Good. His tongue stays midline with no fasciculation, so that's good. Good. Now, I'm gonna look at his neck. I'm looking at his trachea. I'm gonna palpate it real quick. There's no deviations, and it's midline to his neck. Now I'm going to palpate for the thyroid gland. I'm gonna turn it this way, and then if you could swallow for me. Very good. All right. I don't feel any goiters, and then I'm also gonna palpate his carotid artery. Okay, and the other side. And there, both sides are +2 bilaterally. I'm going to listen for bruits over the carotid artery. First, my diaphragm. Now with my bell. And I don't hear any, which is good. Now I'm going to have my patient face his back to the camera. So we're going to look at his posterior chest. Alright, we're looking for any signs and symptoms of respiratory distress, so that's cyanosis, pursed up breathing, tripod positioning, use of accessory muscles, tachypnea, dyspnea, I think I said pursed up breathing already. I don't see any. His chest looks symmetrical. There's no obvious deformities. I'm going to test for chest expansion, so if you could just breathe in now. Good. Good, so his chest expands symmetrically. Now we're going to do tactile fremitus. When you feel my hands, please say 99.
99, 99, 99.
Very good. Now I'm going to percuss the intercostal spaces. All right, and I hear tympanic sounds. I'm going to listen to his posterior chest. You can just breathe normal. I'm going to start over the scapula. And I hear vesicular sounds, no adventitious sounds, which is good. Now we're going to do some tests for consolidation. We're going to do egophony first. Whenever you feel my stethoscope, if you could just say E for me.
E, 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 E.
Very good. Now bronchophy, if you could say 99 when you feel my stethoscope.
99, 99, 99, 99, 99, 99.
Very good. And now whisper pictorially, if you could just whisper 1, 2, 3 when you feel my stethoscope.
1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3.
Very good. All right, if you could turn your chest to the front. Now I'm looking at his anterior chest. Again, signs and symptoms of respiratory distress. I'm not seeing any. There's no obvious deformities to his chest. We're going to do chest expansion again. So if you could just breathe in and out for me. Good, and out. Very good. His chest expands symmetrically. Now we're going to do tactile fremitus again. So whenever you feel my hands, if you could just say 99.
99, 99, 99.
Very good. Now I'm going to listen to his anterior chest first for his breath sounds. You can just breathe normally. Okay, I hear vesicular sounds. I don't hear any adventitious sounds. Now I'm going to listen to his heart, starting with my diaphragm. The second intercostal space right of the sternal border is aortic. The second intercostal space left of the sternal border is pulmonic. The third intercostal space left of the sternal border is Erb's point. The fourth intercostal space left of the sternal border is mitral, or tricuspid, excuse me. And the fifth intercostal space left of the sternal border is mitral. Now again with my bell, aortic, pulmonic, Erb's point, tricuspid, and mitral. Right here is the patient's PMI. I'm going to listen for a whole minute and tell you his pulse. All right, the patient's pulse is 73. He has a normal rate and rhythm, and I do hear S1 and S2 sounds. Now I'm going to have the patient lie on the bed at a 30 to 45 degree angle. We're going to test for jugular vein distension, so I'll hold you. You can look that way, now this way, and I don't see any jugular vein distension. I'm going to let him go. All right, now I'm looking for any heaves or lifts. I don't see any. I'm going to palpate where I just listened to for any thrills. So we've got aortic, pulmonic, Erb's point, tricuspid, and mitral. I don't feel any thrills, so that's good. Now I'm going to listen to those points again. First is my diaphragm. So we've got aortic, pulmonic, Erb's point, tricuspid, and mitral. Now my bell, aortic, pulmonic, Erb's point, tricuspid, and mitral. Again, S1 and S2 sounds are heard, no extra sounds, and he has a regular rate and rhythm. I'm now going to listen to the arteries to make sure there's no bruits. So we've got aorta, renal, iliac, and per the patient's request, he's going to say clothes, so we're going to listen a little bit higher, but the femoral are lower to the groin. Femoral, now with my bell, aorta, renal, iliac, and femoral. And I don't hear any bruise, so that's good. Now I'm looking at the patient's abdomen. It is flat, it's not distended, and it's rising symmetrically, so that's good. I'm going to listen to his vowel sound starting in the right lower quadrant. And usually I would listen for 5 minutes. His vowel sounds are normal active. Now I'm going to percuss his stomach. Starting in the right lower quadrant. And all those sounds sounded tympanic to me. I'm now going to do light and deep palpation. And I didn't feel any masses. Was that tender?
No.
I'm going to do deep palpation. Was any of that tender?
No.
And I didn't feel any masses then either. So on the right upper quadrant of the patient's abdomen is the liver. So I'm going to ask him to inhale. I'm going to palpate his liver. Okay, and then on the left side is his spleen. I'm going to ask him to take another deep breath and palpate his spleen. So I can't feel his spleen, but I can feel his liver. If the patient will return to the chair and face his back to the camera so we can do some CBA tenderness. All right, when I knock on your back, you let me know if this is tender, okay?
No.
Good. All right, we're going to face the front. Now I'm going to look at the patient's upper extremities. I'm going to palpate his fingers, his wrists, his elbows, and his shoulders, and I'm looking for crepitus, temperature, nodules, tenderness, or any of those tenderness.
No.
Any deformity. They look symmetrical. There's no obvious deformities. He indicates that it's not tender, so that's good. His skin on his upper and lower extremities is dry and warm. I'm also looking for texture, turgor, temperature, moisture, scars, bruising, lesions, and nevi. I don't see any. His skin is intact. It looks like it has good turgor. His skin is warm and dry to the touch. Now looking at his fingers, I'm going to do his capillary refill. And that's all less than 3 seconds, so that's good. We're going to do his radial pulses. Those are all 2+. Now let's do some range of motion with our fingers. So we're going to flex, extend, hyperextend, abduct, adduct, then do thumb opposition. So just tap, 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 tap. Very good. Now let's do our wrist. We're going to flex, extend, hyperextend. We're going to radial deviate. We're going to ulnar deviate, and then we're going to circumduct. Cool. Now with our elbows, we're going to flex, extend, and hyperextend. Good. Now for our shoulders, we're going to flex, extend, hyperextend, abduct away, adduct in, internal rotation, external rotation, and circumduct. Very good. Sorry. Cranial nerve 11 is the accessory muscle. So we're going to have him shrug his shoulders fluidly for me. Thank you. And now let's do, we're going to do strengths of these upper extremities. So if you could squeeze my hands for me hard as you can. Very good. Now if you'll flex against me. Good. And flex your biceps. So there we go. If you'll abduct away. Good. And adduct in. Good. So all his strengths are 5 out of 5 there. Now I'm going to have you, we're going to do some more sensory things. So close your eyes for me and tell me whenever you feel the sensation, okay? So we're going to do upper and lower extremity.
Now. 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 Now.
Very good. Now, if you keep your eyes closed for me, we're going to do some graphesthesia and sterigenosis. First, we're going to do sterigenosis. Tell me what's in this hand.
Battery.
Okay, and tell me what's in this hand.
Paperclip.
Very good. I'll take both those back. Now I'm going to draw on your hands. You tell me what I draw.
T.
Good.
0.
Very good. All right.
Circle.
Yes. Now we're going to do some vibratory sensation real quick. I'm going to do it on your upper extremities. Tell me if you can feel this.
Yep.
Good.
Yep.
Now your lowers.
Yep.
Okay.
Yep.
Good. Now we're going to do some deep tendon reflexes before we move on to your lower extremities. We're going to do your radials, your brachioradialis, your bicep, your triceps, hang that loose, your patellar, your Achilles, and then your Babinski. All right, so those are all intact, that's good. Now before we move on, let's do some quick cerebellar test. You're gonna flap your hands back and forth. Very good. Now you're gonna do with me, finger to finger. Great. Now I want you, whenever you see my finger, I want you to touch your nose, touch my finger, okay? So touch your nose, touch my finger, again, again, again. Great. All right, so now I'm gonna look at his lower extremities. I'm looking at his feet, his ankles, his knees, and his hips, and I'm palpating again for that crepitus, nodules, swelling, redness, tenderness. Was he that?
No.
Okay. And I don't see any deformities. They all look symmetrical to me. Looking at his skin again, it's dry and warm to the touch. Everything's intact. There's no scars, bruising, lesions, nevi, or moles, so that's good. I'm going to do his capillary refill of his toes. All right, and that's all less than 3 seconds. I'm going to do, you can put them down. Yeah. And I'm going to do his dorsalis pedis pulses. Those are 2+. His posterior tibial pulses, those are 2+. Now we're going to do some range of motion with our toes. So if you could flex, extend, hyperextend, abduct them away, adduct them in. Good job. Now our ankles, we're going to plantar flex down, dorsiflex up, inversion, eversion, and rotation. Very good. And so now I want to do the strengths of these things. So if you'll plantar flex down for me and dorsiflex up, good. Now if you'll flex your knees out for me, or sorry, extend your knees out and then flex them in, good. Now for your hips, if you'll abduct away, good, and adduct in, good, and all that's 5 out of 5, just like his upper extremities. Now I'm going to have you stand up for me, and we're going to do some range of motion for those body parts. So I'm going to have you, we'll start with your knees. So let's flex, extend, hyperextend, good, and flex, extend, hyperextend, good. Let's do our hips. So again, flex, extend, hyperextend, abduct, adduct, inversion, eversion, circumduction, cool. Now let's flex, extend, hyperextend, abduct away, adduct in, inversion, eversion, circumduction. Now I'm going to just turn you over first before you bend down. I'm looking for a curvature and alignment of his spine. See this tender?
No.
I don't feel or see anything abnormal. If you'll bend over for me. Again, looking for those signs of scoliosis. Following the curvature of his spine, it looks good, it looks symmetrical, and he said it's not tender, you can sit up. Now if you'll face the camera, we'll do some range of motion for our spine. So let's flex, extend, hyperextend, laterally flex, and circumduct. And now let's do our cervical spine. We're gonna flex, extend, hyperextend, laterally flex, roll it all the way around, circumduction, great. Now I'm going to have you close your eyes for me, stand perfectly still. Good, this is a negative Romberg test, that's great. So if you'll back up to that corner by the bed, and if you'll walk normally for me, and turn and walk back heel to toe. Good, that's tandem walking, very good. All right, and now if you will hop on one foot and hop on the other. All right, and that will end my head to toe assessment. Thank you to my patient.